All right. Yeah. Good afternoon, everybody. We'll start our last session now. Our final key speaker for today's event is Dr. Debbie Mason, who many of you will already know, and she's going to present multiple sclerosis research and New Zealand perspective. Multiple sclerosis is an autoimmune disease that causes inflammation within the nervous system. It may lead to neurological problems, including impaired vision, balance, and coordination and walking difficulties. Although there are a number of treatments that may modify the disease course, there's currently no cure. This disease affects about 1 in every 1,400 New Zealanders. In this lecture, Dr. Mason will discuss MS prevalence in New Zealand and will provide an overview of her latest study leading the New Zealand part of the world's first clinical trial into whether a vitamin D supplement can help prevent MS. It is believed New Zealanders have susceptibility to MS due to New Zealand's low latitude, resulting in low levels of vitamin D. And if we've got time at the end, there'll be questions, but we may not. So anyway, I'd just like you all to welcome Dr. Mason to speak.
Thank you very much. And thank you very much to the Neurological Foundation and to Rosemary for asking me to do this. I always enjoy presenting these things because I think the more knowledge out there, the better. So I'm going to, as Rosemary said, talk about MS, and I'd like to try today and give it a fairly unique sort of New Zealand perspective, because I think MS research in New Zealand is something that we can be proud of. So what I'm going to cover today is I'm going to talk a little bit about what MS is. Not everybody knows sort of what it is. I'm going to talk about how MS affects people in New Zealand, and particularly on some of the impact of MS on people with MS. I'm going to talk briefly too about some of the genetic and environmental things, particularly as they pertain to New Zealand, and then if there's time, and Rosemary lets me, I can talk a little bit about studies that are underway at the moment that I'm pretty excited about. So what is multiple sclerosis? Well, it's an inflammatory disease of the central nervous system. So it affects the brain, spinal cord, and its outreaches, the optic nerves. And it's a condition which we don't know the cause for, but which we do know affects women more than it does men. And this is a picture of Jacqueline Dupree, who was a world-renowned British cellist who very sadly died at the age of 42 from MS. The immune system is implicated in MS, and you can see here that the immune cells within our blood circulation, for some reason which we don't understand, become activated. They then become attracted to the central nervous system, and you can see here that these blood cells then attach to the walls of the blood vessels, and then they traffic out through the blood vessels and then through what we call the blood-brain barrier to cause inflammation within the central nervous system. Now, the cells that they seem to be most attracted to are these cells called myelin. And you can see here that this is a healthy nerve, and it has its nerve fibre, and around the nerve is this protein called myelin. And the protein protects the nerve, provides it with nourishment, and also helps it to rapidly send electrical impulses down the nerve. Now, what happens when there's an immune attack with inflammation, a little bit similar to some of the things that Bronwyn was talking about earlier on, you get these chemokines and this chemical soup that comes in, and it attacks this myelin. And you can see here that these areas become quite moth-eaten, and therefore the nerve doesn't transmit its impulses as it normally does, and you get impairment of neurological function that can affect the sorts of things that Rosemary talked about: vision, balance, sensory symptoms, those sorts of things. And although the myelin has a great deal of capacity to repair, and it certainly does on many occasions, because there's this relentless sort of attack from the immune system, ultimately what happens is that the nerve fibre underneath is damaged, and that unfortunately leads to irreparable damage, which manifests itself in disability. Now, how do we diagnose MS? Well, one of the things that's been very helpful in making the diagnosis and understanding the disease MS is the MRI scan. And this is an MRI scan done sort of through about the level of the midbrain. It's as if I'm standing here at your feet and looking up and have taken a cross-section through. What you can see in the scan is the white stuff, which is water, which normally flows around the brain, and these little pieces here are the ventricles within the brain. And you can see this ribbon that we have of grey matter, what everybody calls the grey matter, the thinking part of the brain, around the outside. And then this slightly darker material, which rather ironically is actually called white matter, where all of those myelin sheaths and fibres run so that they can talk to each other. And what's abnormal about this scan is these white spots. And these represent patches of inflammation and scars that form after inflammation has settled down again. You can see that they're multiple, and these scars obviously leads to the name multiple sclerosis. Now, in historical times, we had thought that MS was predominantly a disease that affected the white matter, and certainly that is the cell that takes the biggest hit. But in recent times, we've become increasingly aware that the areas within the grey matter are also affected. And you can see here, again, Bronwyn was talking about these. This is a neuron, and it too has nerve fibres or axons, which also have myelin on it. And you can see that this one here has been transected by some kind of inflammatory process, and this ultimately will lead to the death of the neuron. And within the grey matter, death of neurons, we think, probably contributes to some of the cognitive impairment that you see in multiple sclerosis, and also ultimately to some of the disability. And if I get time, I'll come back to that, because some of the work that we're doing at the moment, particularly with respect to MRI, is looking at trying to learn more about this process. Now, one of the things that's extremely challenging for people who work in the area of multiple sclerosis and for patients with multiple sclerosis is the diversity of the disease. This is a tremendously heterogeneous disease, and it can range over many, many years and have very different manifestations. This is very hard because when people first develop MS, we don't really have any good way of knowing whether it's going to affect them early or whether they may be a group of patients who go for 20, 30, 40 years without getting a great deal of difficulties. This is one of the big challenges in terms of both caring for people with MS, but also in terms of new treatments and looking at ways of changing the disease course. And I'll talk a bit more about that with respect to the vitamin D. In the majority of people with MS, the disease starts off in a relapsing, remitting form. And what that means is that a person will have, as marked in yellow here, an attack, and that attack will then stay for often a number of weeks, and then they will make a complete recovery. Now, this first attack we call something called a clinically isolated syndrome, or first demyelinating episode. And the reason why we distinguish this first attack is that not everybody who has an attack like this will in fact go on and develop MS, although many will. The problem is that whether they have another attack in 2 years, 3 months, or as I saw a lady just last week in the clinic, another 20 or 30 years is very difficult to predict. What tends to happen is often within 2 years, a person will have yet another episode. It may be similar or something else, and again make a full recovery. And these are the relapsing phase of the disease. Now, over time and ultimately, the relapses, which are episodes or waves of inflammation, tend to give way to what we call a more unremitting type of progressive disease. And you can see here that the relapses tend to wane, but unfortunately the recovery from those is less each time, and a person then goes on to develop progressive disability. For a small group of patients, about 10%, the onset of disability will occur from this very early stage. But for the vast majority, the disease comes along as a relapsing, remitting event. So what about New Zealand? Well, we've always known that New Zealand's a high-risk country with respect to MS. And in fact, this is a cartoon that I've taken out of some work that was done in the 1960s. So you can see that we were known to be a high-risk area right back then. Up until 2006, most of our knowledge about how many people in New Zealand were affected with multiple sclerosis came from these small regional studies. And you can see that they were done over many different years, sort of right back to the early 80s and 60s to the more recent one that was done by Andrew Chancellor in the Bay in 2001. But we didn't know how it affected the entire country. And so in 2006, Professor Bruce Taylor and I formed what was called the Multiple Sclerosis Study Group. And this group we set up to try and ascertain how frequent MS is in New Zealand, and also to try and determine what the impact of this disease is on New Zealand people. It was a unique study in a couple of ways. The first is that it was the first study ever in the world that's been done across a whole country. And the second thing was that we tied the study to the Census in 2006, which you'll remember in March, and which we're just about to have another one of. So it was a huge undertaking, and I can't thank enough the people from around the country, patients, neurologists, MS societies, and the people that were involved in this. To get a cross-section or a snapshot of MS on Census Day in 2006 was a big job. We had nearly 14,000 notifications, and we identified about 6,000 unique individuals from that. That resulted in us being able to confirm that there were just over 3,000 people in New Zealand who had multiple sclerosis. That gave New Zealand a prevalence which is not the highest in the world, but it's certainly quite high. Not quite as high as some of our Scottish colleagues and things, but certainly higher than many of the countries like Japan, of 72 per 100,000. It confirmed what we thought, that this disease affects women for reasons which we don't understand, more than men, and that it is fairly rare in Maori. It appears that Maori people, for whatever reason, seem to be protected from this condition. And that is true of other Indigenous groups as well. Now you can see from this that it affects people across a wide range of ages. And although the prevalence is highest in the sort of 60s, certainly the number of people with this condition is within the sort of 40s and 50s, the years in which people are working, having families and things like that. As part of this study, we also wanted to look at the impact of the disease on people, and so we investigated and got these disability assessments on every person that we identified. And this is a validated assessment tool that we use in neurology called the Extended Disability Status Score, which basically gives us an idea of being able to compare how disabled people are. A score less than 3 is a relatively mild disability, some impairment and nuisance factors. Between 3 and 5.5, people have a moderate degree of disability, but they're still able to walk without any assistance. Between 6 and 7.5, people need some kind of assistance to walk, and then the group with severe disability of 8 and 9.5. And you can see that although there's lots of people who do have mild disability, there is also a significant group within New Zealand of people with moderate to severe disability. These kinds of things will be helpful when we are trying to get justification for various medications and other things for funding for people with this condition. And not surprisingly, as part of the study, people filled in a survey for us very kindly, and our response rate was really very good. Over 70% of people filled in a questionnaire, which by questionnaire values is a very high response rate. And not surprisingly, we found that this disease has quite a lot of socio-economic effect on people and has implications for us as a country. While 90% of people with MS had a previous history of work, when we did our survey, over half were not working, compared with 22% of the general population. Not only were they not working, many of them had stopped quite early in the disease course, and we don't completely understand this, but obviously there are lots of reasons that this might occur. So we are losing a huge number of people with a great deal of skills from our workforce, and that this has quite an impact on the person personally and their families, because you can see that the median income for people who are not working and who have MS is significantly lower than the New Zealand mean, and many of these people are receiving invalid benefits. So you will remember I showed you the slide about the regional studies that were done around the country, and this is in this column here. We then did a comparison with the information that we got in 2006. And one of the things that you will notice is that in many areas there has been a significant increase in this disease. Now, these are older studies, but they were generally very well done by people who were very meticulous. And probably some of the ascertainment may have been increased by the fact that we've got MRI now and things like that. But unlike conditions such as stroke and hypertension, which seem to be going down in our community, it appears that this disease is in fact increasing. And I think that's got a lot of implications for the future and a need to continue to investigate this disease more and more. Now, the astute amongst you on that last slide would have noticed also that the rates of multiple sclerosis throughout the country are not uniform. And certainly you can see here that in the Northland regions, Auckland, Northland, the rates are quite a lot different from those in the South Island. And there seems to be sort of some kind of cut-off through this area here. And if here you can see this a little bit more clearly with this schematic here. And above about 37.5 degrees of latitude, the prevalence increases by about 10 people for every degree of latitude. And the differences between north and south It's 3 times more common in the South Island. So now, why is that? Well, I guess it could be a number of factors, but the thing that's probably the most interesting with respect to that is this thing that we call the latitudinal gradient. Now, this is not a new concept. It's been around and known about for a long time. And really nobody still has a good explanation of why MS seems to occur much more frequently in lower latitudes than it does in near the equator. And this is true not only in the southern hemisphere where we live, but also has been demonstrated in the northern hemisphere as well. The thing that one logically thinks of is sunlight exposure. And you can see here in this diagram here that we don't get a lot of sunlight in the winter, which is understandable, but that in the summer months also, particularly in the lower parts of the South Island and high-risk areas in Australia, such as Tasmania, again, our sunlight levels are quite low compared with the equatorial countries, both winter and summer. So this is where the kind of theme with respect to vitamin D arose. And just as a bit of an aside, before I talk about vitamin D, I wanted to just talk about where the name vitamins comes from. That in the sort of the late 1800s, people didn't have any idea about the kind of nutritional value of food. So they thought that a plate of potatoes or a plate of meat or a plate of carrots were all completely equivalent. It was just food that they need. It was just volume, and it was just food that they needed to eat. Then, of course, with a lot of sea travel and things, people recognised diseases like scurvy. And in fact, an interesting aside is that Captain Cook won a scientific award, what was called the Copley Award, for the fact that he managed to prevent all of his sailors, when he came to our waters, getting scurvy. And this was in a time when somewhere between 50 and 60% of the crews on long voyages would die. So the first person to really find a vitamin, if you like, was this guy Casimir Funk, which I thought was a very cool name, who was a Polish biochemist who was working at the Lister Institute, but not until 1912. And he coined this phrase, vital and amens, because he thought that they all had nitrogen in them, which subsequently didn't turn out to be the case, and which is why the E was taken off and they were called vitamins. And he recognised that these were molecules that were not made in the body, but that were vital to it. And I've put here small amounts, and I'll come back to that in a minute. Hence the name vitamin D. We now know, in fact, that the body does make vitamin D, and I'll show you how that is. And in fact, vitamin D is probably a hormone, but it's kept its name anyway. So how do we make, or how do we get vitamin D? Well, most in our country, most of our vitamin D is got from sunlight. We don't really take in a lot of vitamin D in our diet. That's in contrast to places like sort of the Eskimo groups and people like that do eat very high fish diets and other things, which mean that they get most of their source of vitamin D from their diets. But what we do is that we make vitamin D in our skin, and we then store it as an inactive compound within the liver before it goes to the kidney and then gets activated and utilised via that process. And I'll get you just, obviously you don't all have to write this down or learn it, but just have a look at, just remember this little conversion here, which is one of the enzymes that converts the inactive form to the active form, because I'll come back to that again in a minute. So from that, there's now quite a lot of at least anecdotal evidence that vitamin D might be good for us. The problem is that nobody really knows the relevant age or timing, when we need the vitamin D. Nobody knows how much and what type of vitamin D we need, and we still don't know about the safety of vitamin D, particularly in high doses. You will remember that I talked about the Polish biochemist who isolated thiamine. Do you know how much thiamine we need in our entire lifetime? 1 ounce. So 1 ounce of thiamine lasts us our entire lifetime, 70 to 80 years. So the body is a subtle system, and some of its requirements for certain things are very low. And you can imagine that there are a lot of people swallowing bucket loads, literally, of vitamin D. And at this stage, we just don't know whether that's helpful or what that does. Bronwyn made the point about the need for scientific trials, that there's an enormous amount of literature on the internet and others about vitamin D, and a lot of people take vitamin D for all sorts of conditions. But to really understand vitamin D and its impact, particularly in MS, we need to do well-designed scientific studies. And as Rosemary alluded to, I'm very pleased to say that New Zealand and Australia have been leaders in this. The Multiple Sclerosis Research Group in Australia have funded a $2 million funding package for a group of us to investigate whether vitamin D is useful or may help people with MS. And this trial is just about to start in the next few weeks. So what we are doing is, as I said, a proper scientific randomised, double-blind, placebo-controlled trial. Now, you'll remember that I talked a little bit and dwelt on the fact that when people first develop multiple sclerosis, they often have a single attack initially. And we do know that patients with MS are at their most homogeneous at that very, very early stage, because we have quite a reasonable idea from drug trials and others what happens to people in the first 2 or 3 years of the disease. What we're going to do, therefore, in this trial is to target people after their first attack, so before a formal diagnosis of multiple sclerosis has been made. We're going to randomise people to a placebo and 3 different doses of vitamin D, so we can see if there's a dose effect. And then we're going to monitor to see whether the introduction of vitamin D reduces the chance of developing MS or having a second attack. And patients will also have MRI scans looking for new activity on MRI. And this is a 12-month study. We're going to begin recruitment within the next few weeks, and we hope to have the results of this around about 2015. What about other things? We know that the vitamin D may be part of it, but there are obviously other things that have been implicated as well in terms of possible causes, because we don't know what the cause is, so we're very open still to different ideas. There's a line of evidence looking at infections and the role of infections, particularly childhood infections, in triggering this disease. We've talked a little bit about some of the environmental factors, and of course there are genetic factors as well. I bring this slide up again and say, well, you know, perhaps all of these people just have such strong Scottish origins that that's why everybody in the South Island gets MS. And Professor Skegg, who used to be the Vice-Chancellor of Otago University, did a beautiful study a number of years ago when he looked at all the mix and max in the telephone book in the South Island compared with the North Island, which I thought was quite good. And indeed, there are more people of Scottish origin and Northern European origin. But we know that genetics are not the whole story. If you take two identical twins, i.e. they have exactly the same genes, then the chance of one twin getting MS and the other is about 30%. So we knew that genes played a role in MS, and there has been over the last 10 years or more an enormous amount of money and studies done in genes. Literally billions of dollars have been spent looking for genes. Unfortunately, no single gene has been identified, and that it looks like that this, as we thought, is a very heterogeneous disease and is probably relies on multiple genes. So although we don't know the cause of MS, certainly in the last 10 years, all of this research has increased the amount that we do know about the mechanism of the disease. And I'm very pleased to say that New Zealand has also been able to contribute to the genetic knowledge about this disease as well. I mentioned Professor Taylor, and after we had done the prevalence study, we also formed what was called ANS gene. Now, when you do genetic experiments, you need huge numbers of people's blood or saliva to be able to make some kind of meaningful assessment as to whether genes influence the disease or not. And so in about 2007, we set up what was called ANS gene. And I think the thing about ANS gene, to my mind, shows a very important thing about research in New Zealand. We are a very small country, and the funding for research is relatively modest. But the things that we can do is that we can collaborate and we can cooperate and we can contribute in a big way to other people who may have more money than we do. As part of the prevalence study, we asked people with MS whether they would mind if we contacted them again. And very generously, the vast majority said that they would be happy to be contacted again. And so we did. And 2,000 people in New Zealand sent us little bottles of spit, of which we were most appreciative. And we were then able to contribute that to this group here in Australia, and I can tell you now that we have also now formed a connection with the group in Cambridge, who have just published recently a Nature paper in which 29 new genes for MS have been identified, and New Zealand people were all part of that. And in fact, I had a call from the people in Cambridge to say that the New Zealand data was some of the most well documented and methodically done of any of the data that they got. So I think we can be proud of that. This study was also very successful, and we identified 2 new genes that hadn't previously been had not been known about. And one of these, and this is where we come back to that interest, it was in an area of vitamin D metabolism. Now you remember that I showed you that enzyme whereby vitamin D is absorbed and it's stored in the liver, and then it is activated within the kidney. And one of the enzymes that is important for that is this one here called the CYP27, and it is within that area of the gene that we found some genetic associations, and we're currently now walking the genes to see whether this gene might in fact be one of the genes. The other genes were largely immune genes, and so of all of the genes that have been identified to affect MS, the vast majority have been within the immune, in genes within the immune system. So still a lot of work to be done. How am I going for time, Rosemary? Oh, no, sorry. Okay, so I'll talk for a little bit more, and then we could perhaps take some questions. Yeah. So I thought I'd just end the talk by talking about a couple of things that are ongoing at the moment and which we're pretty excited about. You will remember that I talked a bit about the fact that this is a very unpredictable disease, and that what we really need to know is a lot more about the early phase of the disease. This sparked a study which we received funding from, very kindly, from the New Zealand Multiple Sclerosis Society for salary support for. And basically, unlike the prevalence study, which gives you a snapshot of everybody with MS within the country, this study is done to determine each, over a year period, who is getting this condition. So people with new diagnoses or their first episode of demyelination, that thing that I called that CIS, or first demyelinating event. Why is this important? Well, if we're going to change the course of this disease and prevent people from getting disability, it's becoming increasingly aware that we need to do that early. And to do that, we need to know a lot more about the beginning of the disease to help us select those people who will benefit from treatment, but also to know a lot more about what happens in those first 2 to 5 years so that we can address a lot more of the biology of the disease, but also try and alter or change the course early on. Unfortunately, once the disease has reached the stage where there's a lot of neurodegeneration, dying back of those areas that have been damaged, that until Bronwyn's group find that wonderful stem cell and can help us with repair, there is very little we can do. So our options must all be directed at this stage towards trying to prevent the disease. The incident study started in June last year, and again we are relying on the help from people all around the country to try and let us know about everybody who develops this disease and anybody that's had an episode of demyelination. Again, a very big task. Up until last Friday, we had 150 people that had been referred, and our intention is then to follow those people along quite closely and to find out what this condition means to them. The second study, which I'm involved with as part of the NZBRI, is an MRI study, and this is being done with one of our collaborators in London, Dr. David Miller, and also with other people at the NZBRI with enormous expertise in looking at imaging in people with neurological conditions, particularly Parkinson's disease. You will remember that I talked a little bit about those grey matter changes and the fact that we are increasingly, although there's obviously a lot of inflammation and damage going on in the white matter, a lot of the more permanent damage and some of the irreparable damage is also going on in the grey matter. And to date, we haven't really had an effective way of looking at grey matter, or whether in fact it correlates more with disability than perhaps some of the other inflammatory changes, which haven't really been shown to have a very good correlation with what happens to people in the long term. So with Dr. Tracy Meltzer and a few others at the NZBRI, we've developed MRI techniques whereby we can look at early aspects of changes, and we're looking particularly at the way in which the blood flow might change, what we call perfusion, to try and see whether there is some key there very early on that might give us some clues as to what might be going to happen in the future. And one of my research people, Letitia Debnan, has just presented a poster looking at the pilot study with respect to this, which shows that we have found that in people with MS, we are seeing some perfusion changes before they're actually developing damage or atrophy or thinning of certain areas of grey matter. And we now want to do another study and follow that up and see whether, in fact, those perfusion changes, which are reversible, are something that we might be able to give us a clue, and maybe then also able to try treatments that may help in the early phases. So, exciting stuff, and thank you very much for your attention. Is Bronwyn still here? She may have gone. Oh, right, yeah, she may have gone then, yeah, because I just think they were both, yeah.
Are there any first and second generation migrant studies which would give you any clue?
Any migration studies? Yes. So there are a number of migration studies looking at people before and after the age of 15. They're not terribly robust, but what they tend to show is that if you move to a country before the age of 15, then you tend to you pick up the risk of the country you migrate to. Whereas if you move after the age of 15, you tend to keep your risk from the country of origin. And that's what's made us quite interested in looking at whether in fact it is factors in early years that might be the things that predispose people to this disease. And one of the things that we've been looking at, that came out of the prevalence study, is looking to see where people lived in their early years, whether if you lived in Auckland all your life and then just happened to be in Southland on Census Day, whether in fact where you spent the first 5 years of your life alters your risk. And we're just working on exploring that data at the moment. And in fact, that's being done by a group who we collaborate with in Exeter.
Can you tell me, has there been an increased number of people getting MS since the earthquakes?
That's a very good question. And I don't know the answer to that. The reason being that we didn't know how many people each year were getting this disease before the earthquakes. The study that we're doing, which is the incident study, which is counting all the people who developed this disease, didn't start until June last year.
Excuse me, just with the perfusion, and you said it's reversible, is that intended to be through exercise or warmth, or is it oxygen?
Yeah. Excellent question. The levels of perfusion that we're looking at probably are looking at a cellular level. So it's not to do with how much the heart is putting out blood flow, but in fact the cellular requirements at a sort of a molecular level of the cells themselves, which may be related to the metabolism of the cells and the metabolic function and its oxygen requirements. So if you see cells that are low in their needs for blood, hypoperfused, that tends to indicate that the cell, for some reason, is either not happy or its requirements for oxygen have gone down. And that may be a cell that is in some way stressed. I'll get them to bring. Could you bring, after this question, could you bring the microphone down? There's one question down the front too. Yes.
The change in the perfusion, is that where the CCSVI stuff all came around?
No, again, this is perfusion that we are looking at a cellular level.
Right. My GP says you can't win, you need to get the sun, but it's very harsh in this country and you have a high risk of skin cancers. On April the 4th, I'm having my second skin cancer cut out. If they say we need to get our 15 minutes of noonday sun, how can we safely achieve that?
Absolutely, and I think that has certainly been the experience in Norway as well, where when people decided that vitamin D was very important to them and they increased their sun exposure, their rates of skin cancer went up. That is why looking at other ways of substituting rather than the sun, such as vitamin D in sort of oral tablets, is so important, I think, because advice to tell people just to go out and get more sun exposure isn't the answer. And what we would need to do is to do that in a responsible way, knowing that we're using safe types of values. Now, there are the New Zealand Cancer Society and the Australian Cancer Society have done quite a lot of work around this, about what safe levels of exposure are. And there's more and more data about looking at blood levels of vitamin D related to that. But it's an area where there's still a lot of work to be done.
I have a question about looking at the first episode of Demyelination and the research you're doing there, which sounds quite exciting, getting onto it early and, hopefully improving the outcomes for disease progression. But my understanding is at the moment Pharmac won't fund any treatment until you are having multiple flares in a year. And that sounds like it's much further down the track. So with your research, are you sort of hopeful that if you do find something that Pharmac will come to the party a bit earlier?
Yeah, absolutely. I think that not so much with the vitamin D research, that we're doing, but the incident study. Part of my motivation for doing this was that I think increasingly we are falling behind the rest of the world in the way that we are treating people with MS, and that Pharmac's biggest fear, obviously, always is how many people is this going to mean and how much money is it going to mean. And the only way that we can create a rational approach to them is to do things like the incident study, where we can tell them exactly how many people in a year acquired this disease, and also to follow these people, and then to be able to tell Pharmac, look, these people are beginning to get disability at 2 years or 4 years and 5 years, and so that we can then sort of make a much more rational plea to be able to, and we can then compare ourselves with the rest of the world and say, well, look, New Zealand people are being disadvantaged. We are gaining more disability than other groups because we're not treating people.
I just want to ask about how MS affects hypersensitivity with smell and hearing.
With smell and hearing?
Yeah, and touch. With the hypersensitivity, how MS affects that with the brain.
Yeah, so on the whole, although not obviously in everybody, hearing seems to be something that is very rarely affected in MS. There are different organs that are affected more than others, and hearing seems to be, although it can be affected, it's very, very rare. Certainly, sensibilities like touch and things definitely can be affected. And one of the things that we saw with that stripping back of the myelin is that if that affects the sensory nerves, it means that they are more sensitive, and often you get hypersensitivity, and in many people that can even cause pain in arms and legs where the sensory nerves have been affected. Right, I think that's it. Great, thank you very much.
Thank you, Dr. Mason, and also the other speakers. I don't know, I've just seen Dr. Connor's just left. I think Dr. Syncop's probably gone too. But it's been a fascinating day. Talks have been interesting. We learned all sorts of things, I have anyway, that I never knew before. So, and I do thank the people for giving up their time. And I'd also like to thank the audience for coming along, because without you there'd be no point in us giving the speaks. And the next thing is that if anybody wants to register with the Neurological Foundation, you get Headlines magazine and get an update as to what's happening with the research projects and everything. And we'd also like to thank the team at the New Zealand Brain Research Institute and to all our volunteers who've helped today. And my next thing is, it has a reminder, she's come, competition draw. Dr. Mason's going to pull the names out of the hat, which is a box. And don't worry, we'll contact people if they're not here.
So we've got M. Clark.
Yeah. We've got M. Clark from Redwood, Christchurch. No?
Do we have an address for them?
Yes, we have.
Okay.
Yeah, we have an address for them. You have this, yeah.
Someone who's here, maybe.
Right, Jenny Neville. Jenny Neville here? There's an address for her as well, so... oh, dear. Someone's going to be busy dropping the books around. Thank you. M. Hodgson. No? Oh, they've all left addresses, so I'm sorry about that. None of you have received the book. But thank you all for coming, and we look forward to seeing you again, and we look forward to hearing about all the achievements and all the research and the vitamin D, and just take things in moderation, don't OD on it. So thank you all, and enjoy the rest of the weekend.
Great. Thank you very much.
Oh, thank you very much.
Thank you.
You're going to get
It's a shame.